have been just for Turkish fellows, and he wanted me to do some, introduction about how things evolved around my career, since it was never very straightforward for me. And I went through a lot of actually, different places. And, so I'm just going to go through those things. But I'm currently a faculty actually at Seattle Children's Hospital, University of Washington. So little did I know actually that I would ever go to Seattle when I watched this movie in 1993 after one of my midterms in microbiology. I really clearly remember the day. And I didn't even know where Seattle was at the time on the world map. And then eventually, obviously, I watched Frasier, still watching Grey's Anatomy, drank all the coffees, used my computer and everything. But eventually, I'm just long story short, actually, I was born in Turkey. And then eventually, for my dad's career, we moved to Germany because he was also a medical resident. He did double residency in general surgery and OBGYN. Eventually, we came back to my own country, which I miss very, very much right now. The food, the scenes and everything. My heart actually full of the love to my country. Went to medical school in Istanbul University, did my residency, and eventually I transitioned actually for my fellowship in Pediatric ID, which is completely different from what it is now, to Marmara University, where I met actually all these amazing people that are now in front of me. And then right after, probably about 2 weeks after I finished my fellowship at Marmara, I took my almost 2-year-old child, and we said with my husband, let's go and do some research. And we actually went to New Orleans, Louisiana. You can see how young I was at the time. And my main thing was actually to see more HIV, since HIV patients have been very little in the number, obviously in Turkey at the time. So I went to Tulane, and then, very surprisingly, we got a letter in the mail in our Turkish home address, Turkish mailbox, which was saying that we got the green card in the lottery. So we said, how about we spend 5 more years and turn it into actually a citizenship, so our, son at the time could use it. So that's why we actually went into this whole adventure. So I actually took my year civilese again. I did residency. My husband started his cardiology fellowship at Tulane. And then eventually, to finish our actually training, we went to Boston and finished our training. And then eventually, just to get, not rid of, but, we were very tired about all the snowstorms and all the cold weather. Eventually, we decided as a family to move to Seattle. So Seattle, as you know, is actually at the very far northwest spot in the country, but it's beautiful. The climate is amazing. It's very actually similar to what it is in Turkey. 4 seasons. You get some snow, but it's only probably for about 1 or 2 weeks at a time. And it's a big hospital which actually serves a lot of states. You would be surprised actually that it covers such a big surface area in the country. But I should say that actually that the population that we serve is probably not more than 25 million, but the surface area is very wide. So Oregon, has their own 1 or 2 pulmonologists. Montana has 1 pulmonologist who also serves as a sleep medicine doctor. No pulmonologist in Wyoming. Alaska has 1 actually pulmonologist, and he is very, very senior, almost retiring. Hawaii has 1 pulmonologist actually in the military. So it is very, very small. So pulmonologists are very scarcely found actually around the country. So that means we get all these referrals to Washington State. And people have to travel actually for, even the eastern part of Washington takes about 8 to 10 hours to drive over to us. And a lot of times they take flights. So we have to plan really wisely when we see all these patients for their tests and everything. So, but with the passion of being a pulmonologist, we try our best all the time. And I had a lot of coffee this morning. So, forgive me for my really, loose and drunk brain. I really want to actually start very basic about interstitial lung diseases, since Dr. Andy Bush actually had given the first lecture about this, and it was an amazing lecture, very comprehensive about the genetic actually diseases, and it was a wide spectrum lecture that he had given at the time. It's probably about 2 months ago. So as you know, interstitial lung diseases are very heterogeneous and they're mostly chronic, can be seen at any age, any time between newborn era, infancy to elderly age groups, and more frequently seen in adult patients. So that's why actually sometimes actually we lose our attention and we get distracted from ILDs when we think about differentials. The approximate incidence is very low, as you can see, only one case in about 100,000 population. However, it's associated with very high morbidity and mortality. And it's obviously, as you know, it's the umbrella diagnosis for a lot of things. It refers to the disorders of the respiratory support tissues, although it includes the interstitium for the bronchivascular tree, the pulmonary parenchyma, and also the peripheral interstitium for the component adjacent to the pleura. So it is actually a diffuse lung disease, as it also affects the alveoli, which is adjacent and the distal part of the small airways and the conducting zone. So it's probably a better term to use a diffuse lung disease term instead of interstitial lung disease, since the alveoli and the conducting zones are also affected. So since it's affecting such a wide spectrum of places in the lung tissue, the alveolar epithelium, interstitium, and the capillary epithelium, we usually expect abnormal PFTs. One thing, if we forget about all of these, things about this diffuse lung disease, is that we have to know and we have to always remember that it is the progressive remodeling of the alveolar capillary barrier. So that's why that's another important reason why we would most commonly see an abnormal PFT. So the main mechanism for the lung remodeling lies because of repeated injuries of the vulnerable alveolar epithelial cells, and there is an aberrant activation of the epithelial cells and the fibroblasts. And since the alveoli are repeatedly injured and they cannot correctly respond to the injury, it happens that actually the alveoli change in their phenotype and the function, which actually causes crosstalk between the alveolar epithelial cells, and basically they turn into mesenchymal cells and they lose their function. With this increased transition and exaggerated production of collagen extracellular matrix components, the basis of diffuse lung diseases come up. Obviously, any genetic and non-genetic insults increase the vulnerability of the alveolar epithelial cells to repeated injuries. There are other etiologies. So the first slide that I mentioned was the basic actually hypothesis for all these diffuse lung diseases, but there are other etiologies which are most commonly always researched. One of them is the endoplasmic reticulum stress, which is associated with the accumulation of misfolded proteins and activation of these unfolded protein responses, which causes stress and again causes significant apoptosis, which again causes aberrant actually problems. Genetic factors, as we talked, especially in the neonatal era, surfactant protein gene defects with increased ages, especially with IPF, mutations in a telomere function can cause these problems. And obviously environmental factors such as, it says tobacco, but I would probably say any type of inhalants. For instance, last week I've seen a kid with ILD, which was inhaling, who was basically burning rubber and inhaling the rubber. Exposure to any aero contaminants and different types of viruses, which can actually start to cascade. So just to summarize again here, so with the injury, epithelial cells get lost and there's a transition to the mesenchymal cells. And the dominant role is actually by the TGF-beta, which causes apoptosis, causes endoplasmic reticulum stress, and abnormal folded proteins can cause additional stress. It's a vicious cycle to the ERs. And then eventually some tissue can regenerate normally. However, with recurrent injuries, there can be also aberrant repairs. So with these repetitive micro injuries, these symptoms accelerate really fast. And with age, actually, these repairs get also harder and harder. So when we say diffuse lung disease, there are different types of classifications, and especially in adult age, these are very, very different. As you know, for a lot of these classifications, especially in adult population, they would talk about non-specific interstitial pneumonitis, diffuse interstitial pneumonitis, acute interstitial pneumonitis, usually interstitial pneumonitis. But none of these are actually something that we could use for the pediatric age group, since none of these diffuse lung diseases that we see in this age group really fit into one category, and they can really overlap. But for our purposes in the pediatric age group, after getting a good review and ruling out environmental components, we can obviously, with a full review of systems and pulmonary exams, we can classify them in a different way. If there's an environmental component, we can look for serum antibodies, and especially for hypersensitive pneumonitis, we can a lot of times can find an offending antigen. And then with a history, we can also rule out any type of medication, drugs, and radiation, which can cause interstitial lung diseases. And then again, with presenting clinical manifestations, if there are extrapulmonary manifestations, we can look for serum antibodies, and we can do an organ-involved biopsy, which can eventually lead us to a systemic disease associated interstitial lung disease, such as connective tissue diseases, pulmonary vasculitis, granulomatous diseases, metabolic disorders, Langerhans cell histiocytosis, and other diseases. And then if we cannot find anything, if it doesn't fit really into any picture, we can get a lung biopsy to rule out all these structure-related problems. And then obviously we have ILDs very specific to infancy, such as the PIG, knee-high, chronic pneumonitis in infancy, and other developmental abnormalities. So today, actually, I'm going to talk just about the connective tissue disease-related interstitial lung diseases. So a lot of people actually don't like the interstitial lung diseases because it's usually found to be very extreme, but it's very important for pulmonologists to be very familiar to connective tissue diseases. And I think that actually, fellowship is a very good time to actually meddle into what rheumatology has been doing, and actually, just talk with them and do some research as much as we can. Number one, the pulmonary involvement can be very high depending on the connective tissue disease. And sometimes the pulmonary diseases just present as initial clinical presentation, a subset of these patients. And over the years, actually, these patients can evolve with other extrapulmonary findings and pronounce themselves as these connective tissue diseases. So practically, we have to be a team. And a lot of times in my institution, for instance, we act together and have a lot of meetings together with pulmonary, plus rheumatology, plus immunology, radiology, and actually pathology. So, and general surgeon, obviously, if he or she needs to do a lung biopsy. So we really act as a team, and I think that's the key for better patient care. So we all know these, from medical school to residency, and a lot of these, I just put it down actually for for general reminders about which parameters and which serologies actually have been sent for a lot of these connective tissue diseases. I'm gonna probably have enough time to talk about only 4 or 5 of these connective tissue diseases, and I'm not gonna go into a lot of the other granulomatous disease and vasculitis, as I mentioned. It's just gonna be connective tissue diseases. And then again, the SCL70 for SSC, the ANCA, vasculitis, I'm not going to talk about. So this table is actually a very good table that I really have to remind myself very frequently. So this is for pulmonary presentations, not necessarily for interstitial lung diseases. It's from Kendick. So the frequency at initial presentation for pulmonary diseases, as you can see, is mostly seen in lupus and scleroderma, and I always, obviously, sarcoidosis. But, again, I'm going to talk about the first 5 of these. And then very impressively, I always, I get kind of scared actually when I see a scleroderma patient or a mixed connective tissue disease, because I know that these patients would actually behave more aggressively over the years. And then during the course of the disease, as you can see, a lot of these, will pronounce themselves with more pulmonary problems. Juvenile dermatomyositis, as you can imagine, it's more a problem with chest wall. If there's a pleural problem, we always have to think about JIA and lupus. All of these diseases can present at one point with bronchiectasis, since a lot of them with immune suppression can cause a lot of recurrent infections. And also if there is actually dysphagia related to any of these baseline muscle-related problems, that can also cause some bronchiectasis. When we look at diffuse lung disease or interstitial lung diseases, systemic sclerosis and mixed connective tissue are the most pronounced ones. And pulmonary hypertension, again, is a very important presentation for systemic sclerosis and mixed connective tissue disease. So I'm going to start with JIA. It's the most common chronic rheumatic disease in childhood. And I'm not going to go into a lot of details about how it presents, but usually it presents in less than 16 years of age, and it will persist chronically for at least 6 weeks. It's seen most often in females. And a lot of times it can present anytime between 1 year of age to 16, and it peaks around 1 to 3 years of age. However, if you see a diagnosis of JIA in kids less than 6 months of age, you have to be suspicious and look for another reason. Again, obviously rheumatologists, again, just to emphasize, and I'm going to do a lot of case presentations today, rheumatologists know what they're doing, right? So, but as pulmonologists, we have to advocate for the kids. We have to. Sometimes rheumatology can concentrate mostly actually on their parts, on muscles, joints, swelling, inflammation. And even if they do a full review of systems, including pulmonary symptoms, sometimes I think it's not, what should I say? I'm not going to say it's undermined, but we should probably really pay attention as pulmonologists to one system rather than looking at all different review systems like the rheumatologists do, and advocate for these patients. Another thing that makes me really close to these patient populations is that these patients, starting at a very young age, are exposed to very chronic pain. And sometimes patients actually just fall into tears, and I'm not sure if I'm so talented in making them cry during my clinic visits, but a lot of them actually say that whatever they take, their pain is not very well controlled. And the least that we can do as pulmonologists is actually take their dyspneas away. So we have to really pay attention to these patients. So there are different types of, JIAs, not going to go into those details. The pulmonary involvement in JIA is rare. It's only about 4% of these patients. And you can see different abnormalities such as pneumonitis, interstitial reticular and nodular infiltrates, and pleural effusions. And the most common finding is the pleuritis. It's well reported, especially in systemic JIA, and it can be also accompanied by pericarditis. But if a patient just comes in with pleuritis, we have to rule out also lupus as part of the differential. Significant pulmonary manifestations in general are rare in JIA. However, if it's systemic JIA and polyarticular JIA, it becomes more often, and especially systemic JIA can be actually with increased morbidity and mortality. They can have aspiration, significant pulmonary hypertension unrelated to parenchymal disease, and pulmonary fibrosis. And I think the most important way they usually present is macrophage activation syndrome. I still remember actually one child when I was an infectious disease fellow at Marmara who was diagnosed with Kawasaki's disease, but the lesions, the skin lesions were not really typical. So the little boy, he was 2 years of age, that was my first time actually meeting a systemic JIA kid with MAS. He got 2 doses of IVIG, such as, for the diagnosis of Kawasaki, but in fact, he had MAS and he passed away over the next week or so. So it can be really aggressive. For JIA, especially, even for the general JIA treatment, usually non-steroids, intra-articular steroids, low-dose weak methotrexates are the mainstay of the treatment. And eventually, depending on presentation, they can have TNF-alpha inhibitors, systemic corticosteroids. And then if it's not really well controlled, you can go to IL-1 antagonists and IL-6 antagonists, which is widely used in a lot of these rheum patients. But if there's MAS, then you have to really consider the early use of cyclosporins or IL-1 inhibitors. If it's acute pleuritis, a lot of times they can just respond very well with non-steroids and also basic treatments of methotrexate and steroids. But if there's leukoid pneumonia and pulmonary fibrosis, they need more attention. Obviously, if it's MAS, it comes with high mortality and complications. So I'm going to actually start with a little kid. And again, you know, when I'm presenting these patients, I want to emphasize that we serve actually at least 6-7 states. This child was actually 2 years of age when he presented. And even if this clubbing is not actually very impressive in Turkey, and I've seen many kids with clubbing actually in the past who were not diagnosed with CF, obviously this is all in the 90s. This was very impressive for the United States. So this kid was actually having a background story of congenital heart disease, DiGeorge, had vocal cord dysfunction, vocal cord paralysis, and had some dysphagia symptoms, was recently diagnosed with systemic JIA, followed up by rheumatology in the community, not at Seattle Children's, and was referred to me actually for rule out lung disease, since this child had one admission in the setting of rhinovirus and had an ICU stay with some BiPAP use, and had some ground glass opacities in a chest CT that had been obtained in the acute setting. So she was started actually on IV pulse steroids and oral prednisone at diagnosis, started on eventually weekly, PO methotrexate, and then added on IV tocilizumab, which had caused erythematous rash with swelling, and then was switched to subcutaneous tocilizumab with ongoing pruritus and rash. So this child I'd seen probably once or twice in the clinic, and I was trying to get documents in, and again, like, you know, they're coming from very far away, and communication is sometimes not very easy actually with families and the primary providers. And then one day when I was checking on a patient actually for something else, mom said, by the way, her aqueous saturation is only 91%. Is that normal? So I said, please come straight to the ER, and we admitted this child, and actually in 2019. So I'm giving these slides for the chest CT only because actually this child had chest CT for the purpose of the heart disease. And this was done when she was 2 days old, eventually after surgery, which was looking fairly okay. And this is the time when I had actually seen him in the clinic and admitted him. And I apologize. So this was actually the setting of the rhinovirus infection when she needed BiPAP in the ICU. Obviously, in acute setting, it's hard to rule out which is acute, which part of the lung disease is acute, and which part of lung disease might have been more chronic. So this is on admission. And I'm going to go forward a little bit. And you'll see actually, you know, that she had very bulky lymph nodes at the time, which can go very commonly together with systemic JIA. She had fibrosis with subpleural sparing with non-specific diffuse ground glass opacities. And then had also these crazy paving with interlobular septal thickening with internal ground glass opacities, which is actually very commonly seen with alveolar proteinosis, but also with pulmonary edema. And obviously on the dependent areas, she had some atelectasis and probably some edema. She had been also on some daily diuretics post-op, actually, her heart disease. So, and she actually, we admitted her, and she had very pronounced MAS at the time. She was started on cyclosporin, weekly solomedrol infusions, and then eventually we had to also start her on anakinra, but this was just before anakinra. Even with the cyclosporin and the weekly solomedrol, you know, we could never actually, in fact, go to biweekly or monthly solomedrol infusion, since she always had some increased symptoms of her systemic JIA. So about 6 months later, after we started IV solomedrol weekly and the cyclosporin, her lymph nodes size had come down. However, she continued to have traction bronchiectasis with persistent fibrosis, and the non-specific dense opacities, especially in the dependent areas, continue to be a problem. And we always thought about it, since this was so persistent, that it was probably actually an ongoing edema and ground glass opacity related to her uncontrolled inflammation and systemic JIA. So as I mentioned, we started pulse cyclosporin, eventually added on MMF, and then right now, actually, we started on anakinra, but if you remember, actually, she had some reaction to the tocilizumab even before we had seen her. And there's some research happening right now for all these kids who have been on biologics and IL-1 antagonists. And this child actually had also side effects to the anakinra, so we stopped it. With her DiGeorge, I was also concerned about any possible immune problems. And she, in fact, did have secondary hypogammaglobulinemia, which is hard to differentiate from the low IgGs, which might have been related to her weekly solomedrol infusions. However, with the DiGeorge, the immunologist thought that it would be actually. Am I muted right now? It gave me, hello, can you hear me?
Yeah, we can hear you.
Okay, the screen was saying that I was muted at one point. So it was hard to differentiate if it could have been actually something related to her DiGeorge, or if it could have been related to the IV solomedrol infusions. So and the IVIG itself can also cause some immune modulation. So the immunologist recommended actually starting monthly IVIG infusions, which we started. But I had to stop the anakinra, as I mentioned. And recently, actually, tofacitinib has been approved in the pediatric age group and for little kids less than 4 years of age. So we just literally gave her the prescription, and she's still waiting for actually the approval. And we hope that actually we can wean her a little bit off the pulse methylprednisolone. Right now, she's still on every 2 weeks of solomedrol infusions. And obviously, as you can imagine, you know, with the bi-weekly solomedrol infusions, she has significant problems with her bone density. Okay, so lupus. So I always think that actually, if you want to wish the worst for anybody, even, you know, you should not even wish it for your enemy, right? You know, lupus and actually systemic sclerosis are probably the worst diseases. Lupus is mostly seen in females. A lot of them have autoantibodies. And it's a dysregulation of both innate and adaptive immune systems. Genes and environmental triggers also play an important role. And it's all amplified by cytokines and chemokines with high inflammation and tissue damage. You have to actually have 7 out of 11 of these criteria to get an official diagnosis of lupus, but sometimes obviously we see less than 7 out of these 11, and it's harder to actually diagnose these patients with lupus at first presentation. Pulmonary involvement is actually quite high, and about up to 40% of them can be diagnosed within the first year of life. And as you can see, actually, at any time during the disease course, actually, they can have a diagnosis. And, you know, anywhere between 1/5 up to 80% of them. Sometimes you can see actually the pulmonary involvement just in the PFTs, even if they do not really relate any symptoms to the providers. And it has a wide spectrum of pulmonary involvement. You know, as I mentioned, they can be just asymptomatic with just findings on imaging studies and abnormal PFTs. Sometimes it can be just mild, and sometimes they can present with really life-threatening problems. Most common features, pleuritis and pleural effusion, you know, with JIA and lupus. They can have their very typical lupus pneumonitis presentation, chronic findings related to interstitial lung disease, pulmonary hemorrhage, pulmonary hypertension. The pulmonary hypertension can be unrelated to the lung disease itself, shrinking lung syndrome, which is mostly seen in adults, and vascular thrombosis, which usually presents with antiphospholipid syndrome. So it's also one of diagnostic criteria, actually, if you remember. It's more frequently seen with a younger age at disease onset. And the longer disease, actually, you can see it more often. They can have pleural effusions, which sometimes can be unilateral as well, although less often. So we should be really careful and should not rule out lupus, actually, if we see the pleural effusion as unilateral. And they can be exudative. So it's not only always as a transudate, it can be also exudative. However, when they present with pleural effusions, it's very important that we rule out infections. Don't forget actually that a lot of these kids are on immune suppressions, and they're also prone to infectious diseases. So The pleural effusion by itself could also be infected and can present with exudations. So the chronic ILD feature of the lupus can follow an acute presentation, which is very slow progressive, with exertional dyspnea, chronic cough, pleuritic chest pain, and rales on physical exam. And the PFCs can be slowly progressive over the course, with most likely a restrictive pattern. In histopathology, although we almost never actually get a lung biopsy on these kids, you can see the alveolar wall thickening, fibrosis, and lymphocytic infiltrates. And when you do some immune staining, you'll see the immunoglobulins and the complements as a granular deposits. Pulmonary hemorrhage, not very often, however, if you see it, get very, very excited and, do the best you can. It presents with severe dyspnea and can present with respiratory failure. In a lot of these patients, lupus nephritis is present and mortality is as high as 50%. X-ray is non-typical, like any other patient can have pulmonary hemorrhage with diffuse alveolar opacities. And you have to actually rule out TTP if there are additional features such as fever, thrombocytopenia, and renal dysfunction. Pulmonary hypertension, as I mentioned, is rare, but can be totally unrelated to the lung disease. So it can be related to pulmonary vasculitis, to thromboembolism, ILD sometimes by itself. If they have heart disease, that can also cause pulmonary hypertension. And most importantly, actually, these kids will have their endothelin levels higher, and the anti-endothelial cell antibodies are elevated. So sometimes because of the endothelin levels are higher, if you remember, the endothelin is also one of the factors that would cause aberrant repair and cause fibrosis. These patients with pulmonary hypertension can also have more fibrosis. Shrinking lung syndrome, this is obviously one of the popular features of lupus, although I've never seen one. It's mostly actually seen in adult patients. I've heard of one child who sounds like 17 years of age, but then, lost to follow-up. It can happen in kids, but, I've never seen it. I've just read about it and heard about it. It can go very insidious. It can be with progressive dyspnea and pleuritic chest pain. You'll see reduced lung volumes with raised hemodiaphragms and basal atelectasis. So the reason is not really clear, but it is thought that actually because of recurrent pleuritis that diaphragms start not to move that much. And overall, actually, it can cause restriction by itself and be one of the mainstays of shrinking lung syndrome. The optimal treatment is unclear. However, as part of lupus treatment, it might respond to immune suppressive treatments. So in lupus in general, actually, only 8% of these kids can have normal findings on chest CTs, such as micronodules, bronchiectasis, and none of these kids had actually interstitial lung disease when they did the screening in Norway. And I would probably trust Norway. And the findings never correlated with PFDs. So the CTs obviously are always more sensitive than regular chest x-rays. Chest CTs are still not routine screening methods of these lupus kids and is not recommended. A lot of times you still have to go with follow-up of the PFTs and also symptoms from patients. PFT abnormalities are seen in at least 1/3 of these patients. As you can imagine, it's mostly restrictive with or without a diffusion abnormality. And there's, again, no correlation between the PFT abnormalities and lupus disease activity. And without symptoms, you can see just abnormal PFTs. You just have to follow it. It's not necessarily criteria to treat unless there are symptoms together with these abnormal PFTs. So this is a very dear patient of mine, actually. When I first saw her, she was just diagnosed with lupus and her FVC and FEV1 were in the 60s. She also had very significant chest wall pain, which we could actually never really resolve over the years. As you can see, the first time I'd seen was about 2.5 years ago. Her TLC was low, She did not really have air trapping, so it was more like a restrictive component that she had. So, and over time, she actually, this was when I first saw her. So because of her shortness of breath that she was describing almost daily, I'd started her on very non-specific treatments with some long-acting beta agonists, with some Advair. And then her chest pain also got a little bit better. She was also seeing pain medicine at the time. And part of her probably, shortness of breath was also related to maybe deconditioning. So we gave her a good regimen for actually exercise program, and she continued to improve her pulmonary functions over time. She got better. And then, here was her peak actually. And I was very proud of her. However, on follow-up, she dropped her PFTs. And I said, and we were concerned with the chest wall problems that she had and her ongoing still mild dyspnea. I was concerned at one point, and she was close to 18, if she could have some shrinking lung syndrome or some interstitial lung disease coming up. So I ordered a chest CT here. And then this poor child actually scheduled a chest CT about a week before she came back positive for COVID. So this was April. So she got admitted, and I think she was one of the first immune suppressed lupus kids that we had to admit actually to the ICU. So a lot of the medications had not been approved by any like world organizations at the time. This was done in an outside institution before she got transferred to us. This was mostly to rule out a PE. She did not have a PE, but she had significant dyspnea. She was on high settings of BiPAP, non-invasive BiPAP. She got treated, she got solomedrol pulse. And then over time, actually, we just continued to follow. This is actually just from last week that I had on her for follow-up. So just to go over her PFDs, this is the time actually when I ordered a chest CT because of her ongoing dyspnea. And as you can see, for 6 months, we could not even order PFDs because she remained COVID positive, probably likely to her immune suppression and her daily prednisone use. And I didn't want to risk actually the PFT lab and the respiratory therapists actually to be exposed to any COVID positivity, even if it might be low titers. But by the time in August, when she was eventually negative, her FEV1s were at 86, her chest X-ray was still abnormal. She still had some dyspnea. So I waited a little bit longer. And then in December, she said that her dyspnea had gotten way better. And it's when I ordered a chest CT, which came back as this, just last week. And I did see her actually just yesterday in the clinic, and she says that she's feeling way better. So the treatments, in general for lupus, especially if there is lung disease involvement, steroids, hydroxychloroquine, AZT, MMF, methotrexate, cyclosporin. If there's pulmonary hemorrhage, you have to really hit them hard with pulse methylprednisolone. Followed for 3 days, followed by high-dose PO prednisone. And sometimes we also continue with weekly and monthly solomedrol infusions for these kids. IV pulse cyclophosphamide and plasmapheresis is sometimes something that we have to consider, especially if there's a pulmonary hemorrhage. Rituximab is one thing that we can still consider. And if there's vascular thrombosis, anticoagulation is still very important for these kids to prevent further PEs. So a lot of treatment algorithms that I'm going to actually just summarize here. If there's interstitial lung disease involvement, first line treatment is glucocorticoids with MMF and IV cyclophosphamide. As a second line, if there's failure of induction, you can add on rituximab or IVIG. And then for maintenance, these kids have to continue with MMF. For pulmonary arterial hypertension, the start is about the same, although you have to add on pulmonary hypertension directed treatments as well. So this is a very interesting patient that I'd seen 2 weeks ago, probably, so in our institution, actually other divisions can also order pulmonary function tests, even if those kids have not been seen by the pulmonary clinic. And I was just reading PFTs as a routine actually care. And I saw this PFT, going down by 50%. And I just red flagged it and sent an email and looked up the chart, obviously. to the rheumatologist, and they said, yeah, this child had COVID in November. And this was just a repeat PFT they had. So up until, then, as you can see, her pulmonary function tests have been like actually fairly good, although her RV was elevated and her RV TLC was mildly elevated, but the rest of it was actually looking very good for FVC and FEV1 values. She was diagnosed when she was 14 years of age, very typical lupus, presented with nephritis, arthritis, thrombocytopenia, and multigonemia. She had also lupus nephritis and CNS lupus with abnormal neuropsych testing as well. She had chorea, and she had also actually a lot of thrombi in different areas, especially in the central nervous system. So she got COVID and she had multiple PEs back in November. Despite being on actually perfect treatment, right? Like in the book, prednisone, MMF, cytoxan, and she was already in rituximab actually when she acquired these multiple PEs, and they kept going with rituximab. They never were able to give her a break actually. So with the multiple PEs, the only thing that they could do is that since she was so maxed out on a lot of her medications, they gave her IVIG 2 doses for her post-COVID inflammation, and that's it. And they gave her actually fondaparinux, which I always have a hard time pronouncing. She's still on it, and they couldn't do anything else. So it's just practically a follow-up on her, but she lost about 50% of her lung function. So I offered actually seeing her in the clinic, and the rheumatologist said, no, she does not have any shortness of breath. And I said, that's not possible. She lost 50% of her lung function. And when I asked her, actually, it turns out that she had a hard time even going up one flight of stairs, which is not a surprise, right? So, so we will continue to follow. She said that she tried Alveolar in the past and it was helping. So the only thing that I could practically do was starting her on long-acting beta agonists just to give her a little bit more reserve for her daily life and increase quality of life. So the prognosis is actually very variable. Disease severity can be more significant in kids in lupus. And the renal disease and infections related to actually immune suppression are the most common causes of death actually in lupus. It's not pulmonary disease. Systemic sclerosis. This is actually, I started from the good actually college and vascular disease going to the most scary ones. Systemic sclerosis is actually very rare. And about 10% of adults can have some type of onset during their childhood, more common in females, up to 4 times. But it can also begin at a mean age as low as 8 years of age. It's whatever we talked about, aberrant injury, aberrant repair, endothelial dysfunction, and VEGF increases happens exactly in systemic sclerosis. All things have been actually contributing to the course of disease. Plus actually both T and B cells are involved. It can involve pretty much every actually system, but I want to highlight the pulmonary problem, and you'll see it's seen very often. So I know that you get very tired now, and my husband even made actually a joke. He said, well, you should check how many of them are in PJs actually. But I'm just going to be fast, from going forward. I know you are getting tired. Since 50% of these kids can have some type of pulmonary involvement, it is actually very worthy to pay attention to these kids, and 80% of them can have interstitial lung diseases. Sometimes aspiration pneumonia by itself can also cause significant problems. So it's an important factor that we have to consider if there's progressive decline in the pulmonary function tests, which is an important result sometimes of severe esophageal dysmotility related to the primary scleroderma problem. So this is a very, very good article that I like. Kristen Hyland is a very well-known actually pulmonologist plus rheumatologist at Cleveland Clinic, adult. And just a very good review. As you can see, actually, systemic sclerosis can involve all systems and even sleep. So the demographics as predictors, even if we don't have African Americans actually in Turkey, male sex and African American race is one of the severe predictors of lung disease. And for imaging, about 20%, greater than 20% enrollment on CTs is an important predictor of the interstitial lung disease. Sometimes kids can be asymptomatic. Sometimes they can just present with dry cough or dyspnea. The findings are not necessarily very specific. They can be a reticular traction bronchiectasis. Most common finding is mostly ground glass opacities. And they can have, just coincidentally, you can find a dilated patulous fluid-filled esophagus, which is mostly a finding related actually to the scleroderma itself and the distal motility related to the scleroderma. This is very typical ground glass opacities with a very fine reticular opacities in the peripheral areas. They can have reduced DLCO, which can be an early marker of ILD and pulmonary arterial hypertension with reduced FVC and restrictive PFT patterns. One thing that is important is that most of the lung volume loss happens actually in the first 4 years of the disease. So immune suppression, especially at initiation of treatment of the scleroderma, is very important. So these are general recommendations from the European Society about the treatment of systemic sclerosis. I'm going to scroll down here. For the pulmonary arterial hypertension, we're not going to talk about it, but it's very important to start focused treatment for the pulmonary arterial hypertension. Cyclophosphamide is very important to start very early during the course of the disease. And bone marrow transplant is actually less often used, but more so and more popular actually, I'm not going to say popular is a bad word. An important actually decision to make for these kids, especially if it's severe disease. And obviously GI, which is, going hand to hand with the pulmonary problems. If they do have reflux because of their distal motility, we should start them on prokinetic drugs and PPI very early in disease, yes. There are several studies which might be need to discuss maybe, at a later time, but they discuss that cyclophosphamide should be considered very early during the course, especially if there is a concern for progressive ILD. A second study through this group is done a comparison for oral cyclophosphamide versus MMF, since the toxicity and the side effects related to cyclophosphamide are so high. And it's very actually comparable. So you could, instead of cyclophosphamide, consider MMF if that's an option. Although with both actually medications, the diffusion capacity continues to decrease. The decrease was less than MMF group and it was better tolerated. So something to consider, especially in this patient population. So B cell infiltration, as we talked, is very actually important. They have higher levels of circulating naive B cells. The memory B cells are activated and they have increased expression of the CD counts. So since they play such an important role, both in lung disease and also in the skin of these patients, rituximab is a very important option that we could consider, especially if there's progression of interstitial lung disease, since it focuses mostly on monoclonal, it's a monoclonal antibody which focuses on CD20 and depletes the B cells. And when they randomized it in 14 patients over 24 weeks, there was significant improvement in both FVC and DLCO over a year, of course. Nintedanib is another option, which is actually used in adults right now very widely. And there is a actually worldwide study right now in Europe. And I'm not sure if Turkey has any patients who have been included. It's I think like 50 patients they want to include only from the US and 50 from Europe. For these pulmonary fibrosis kits, not necessarily for systemic sclerosis, but it does ameliorate the extent of fibrosis. And it, I apologize. And it can help also prevent the pulmonary hypertension. And it's an option actually, especially in adult population these days. In a comparison double-blind randomized controlled trial in patients who had fibrosis of at least 10% of their lungs, they found out that actually in a very comparable group, actually that even if both groups continued to decline, the decline in the nintedanib group was less. And actually, when we look here, it's about 50% less than the placebo group. And diarrhea was the only side effect that could have been seen in the nintedanib group. So it is actually a medication that is encouraged highly in this patient population, especially if there's progressive fibrosis and progressive decline in lung function. Stem cell transplant is another option, especially in resistant patients, which is an important consideration, especially in significant skin sclerosis and significant progression of pulmonary functions. There are different trials. All of them, as you can see, are in adults and in small patient populations, but the overall survival in patients with human stem cell transplant is really high, and the mortality related to the human stem cell transplant is low, as you can see, not very significantly higher than the regular patients who get their stem cell transplant for leukemia or malignancies. So stem cell transplant should be considered for treatment of selected patients with rapidly progressive systemic sclerosis who are at risk of organ failure. So again, those are all pilot studies, and it's not like standard of care. However, it should be highly considered, especially if there are significant eligibilities, such as significant, again, progression of skin scoring for the modified Dornan score, which looks for the sclerosis in the skin. And then if there's major organ involvement, such as pulmonary disease and renal disease, and there are criteria for decrease in the FVC and also for the interstitial lung disease, plus I didn't put in the renal involvement. If that's the case, systemic sclerosis, actually, the stem cell transplant is one option that you could consider in select places. So this is a child, actually, again, I want to get a little bit attention. So this child, again, had been referred from a community rheumatologist, and the question was just rule out pulmonary disease related to Raynaud's phenomenon. So as you can see, actually, when I first saw this kid, the FEV1 was 88%, FVC was 91%. This child had almost no actually significant problems related to pulmonary issues. She had no cough. She was not doing anything. Mom said, oh yeah, when she gets sick, she gets a lingering actually cough, and that's it. She had long distances that she had to walk in her school campus. She was in high school, and she said, yeah, sometimes I get short of breath, but that's it. I don't have any else going on. So we continued to follow, but something was really bothering me about this kid, since, you know, if you think about the scleroderma kids' faces, you know, her face was really pinched, and, you know, her mouth was really small. She had maybe mild clubbing, and I was thinking maybe I'm exaggerating it. So something was really bothering me. So here, actually, she had this decline. And because of lingering cough and intermittent cough episodes, not necessarily because of the decline in the pulmonary function test, I had started her actually on some Flovent only, and she had been feeling better, and her exercise capacity had improved. But here, she had decreased. So this was bothering me. So I ordered a chest CT, which came back normal, but then she continued to decline over here. And I said, this is it. Something is happening with this child. Look at the growth curve. She is losing weight. And at this point, she was not treated with anything by the rheumatologist. I think the rheumatologist was just seeing her every 6 months, no treatment. And I was probably seeing her every 3 months because I was so obsessed about this child. So I said, this weight gain is not a good sign. So I'm going to send you to GI. So GI, and this is the BMI. As you can see, the BMI is also dropping, which is actually an important red flag for these kids, even if you think it's just Raynaud's phenomenon. So the GI person gets also very actually involved, and gets very nervous about this child. So gives her a biopsy, which is completely normal, and then does actually an upper GI with some motility studies. And she says that actually that there's delayed clearance from the esophagus, and she does have certainly some degree of this motility. And the caliber of the duodenum is prominent. It's non-specific, but can be seen in the setting of scleroderma. So at that point, actually, there had been, after talking also with our rheumatologists at our institution, we found out some research that was looking into IVIG, which might be helping with some immune modulation in these kids. We started IVIG, and then eventually, you know, over the following 3 to 6 months, actually, she started to have more pronounced clubbing, and also her skin findings got worse. She was started on MMF. So now she has full-blown systemic sclerosis. So as pulmonologist, even if it's normal, any decline should alarm us for any type of dysmotility, especially in the setting of actually also decreased weight loss and some, vague GI symptoms. So Steve Jobs would say, connect the dots looking forward. I'm sorry, don't connect the dots looking forward, look backwards and try to find them, and trust your gut, destiny, life, karma, whatever. This approach has never let me down, and it has made all the difference in my life. I would have said, trust nobody, never trust a teenager ever, because she was not complaining about anything. And this attitude never let me down in patient care, but don't follow these rules in marriage. Mixed connective tissue disease. Very similar actually in presentation with lupus and systemic sclerosis. However, the diagnosis can be delayed because it's a little bit of everything in my mind. It has a lot of overlapping features, and pulmonary involvement though is still very prominent, although they can be asymptomatic and have a lot of different symptoms. So it's hard to actually differentiate one disease from the other. Their CT findings are very nonspecific, such as ground glass opacities, fibrosis, and sometimes honeycombing and traction bronchiectasis. They can present more often with dysphagia, with esophageal dysmotility, which is very similar to scleroderma. Raynaud's and the antibodies are positive. Related to their disease, and again, aberrant repair, they can have fibrosis on their chest CT, which can also go with higher mortality. For these kids, you have to be also very, very aggressive and start them on treatment very early in life. Very early in disease. And it's actually one of the most common reasons for lung transplant among the patients who do not have scleroderma, but have some type of connective tissue disease. They can have pulmonary arterial hypertension, again, sometimes unrelated actually to their pulmonary problems. And they need screening with anal echoes and the right heart catheterizations as needed. So this is a child that I've seen over the last 1 month. She's 20 years old. We see kids up until 21 who has chronic lung disease of prematurity with spastic CP, scoliosis, who presented with fevers, with worsening cough and decreased energy. About a year ago, she started to have some weight loss, with some gagging. Because she is neurodevelopmentally delayed, she is nonverbal. Her mom is her primary caregiver. She had some weight loss, which was hard to understand. She is fully fed through mouth. She does not have a G-tube. And she started to have a wet cough, actually, which was most prominent at night and was waxing and waning. Was diagnosed with some hemoptysis, and they attributed that one actually to some pneumonia. Started on ceftriaxone, azithromycin. Family thinks that she might have recovered a little bit from that illness. And then in December, she was started with budesonide and alveolar for the chronic ongoing nighttime, especially cough, which did not necessarily have any significant impact on the symptoms. And then 2 weeks prior actually to admission, she was started on CBD oil for some jaw tightness. So something has been really vague for this kid, right? So some wet cough, she had some hemoptysis, some hematemesis, and then she had some jaw tightness, which, because of her unfortunate neurodevelopmental delay, was probably hard actually to look into. And at the time, actually, despite all these treatments, at the time when we had seen her, she had clubbing present. She had no significant skin changes, no skin tightening. She had already the scoliosis from before, and she had diminished muscle mass with contractures in her legs. She eventually became intubated with significant, actually, I thought I had, there you go. So this is actually how she presented: significant scoliosis, so more pronounced findings on the left side. And then eventually she had this diffuse alveolar hemorrhage, which required twice, actually, bronchoalveolar lavage. And then since her symptoms had been so vague, as you can see, more bronchiectasis actually on the left side, probably more pronounced because of the scoliosis. Probably she was also aspirating some, not necessarily to the CBD oil, but to also some dysphagia that she might have had at her baseline. And then because of these vague symptoms, which we could not necessarily 100% lay on actually some connective tissue disease, which was positive for mixed connective tissue disease. We had a lung biopsy, and as you can see, the airway was completely obliterated. Again, we do not necessarily do a lung biopsy on a lot of connective tissue disease, but she has so many vague symptoms. And this was done on a site where her lungs were most affected, so on the left side, left lower side. The airway was completely actually obliterated, and she had cystic remodeling. She had organizing pneumonia and also vasculopathy, actually, with significant thickening of the intima. So she had also pulmonary hypertension. A lot of the compartments had been involved. So she's currently still intubated. Treatment vented right now. She came off BV-ECLS just last week. And her treatment has included actually IV methylprednisolone, IVIG, cyclophosphamide, and she had 3 rounds of plasmapheresis actually. Her ongoing treatment is still weekly IV methylprednisolone, plus now on weaning doses of methylprednisolone, and then cyclophosphamide. And we still have to actually discuss, we did discuss, and we're still in discussion actually with adult folks about what to do next. She's 20 years old as well, so she will be transitioned to adult care very soon. Juvenile dermatomyositis, this is very rare. However, it can go very fast. So a lot of times these patients present with cutaneous and muscle symptoms, and symptomatic lung involvement is very infrequent. However, it's more often in adults. The peak incidence of JDM overall occurs from 5 to 10 years of age. It's more often in females. And again, they'll have your typical presentation with heliotropic rash, Gottrum papules, and muscle weakness, ulcerations, and soft tissue calcifications. Serious GI and lung involvements occurs only occasionally. However, if it is together actually with some genetic mutations, MD5 mutation, it can actually be rapidly progressive and fatal. In adults, again, it's very important to diagnose these kids, but it's very infrequent. In Toronto, actually, it was found only in less than 1% of the kids who had some symptoms related to interstitial lung disease. They can present with pneumomediastinum, aspiration, hypoventilation, and then sometimes the only predictive factor for these kids can be the anti-Jo1 antibodies, but again, only in adults. For PFTs, something that we should consider is actually they can have a restrictive ventilator defect, which reduce the LCO. Their chest CT can be very nonspecific with irregular linear opacities with areas of consolidation ground glass opacities. And very uncommonly, they can have bronchiectasis and honeycombing if there's active inflammation. However, if you think about the muscle involvement, these kids will also have some significant muscle weakness. So we have to differentiate the JDM itself from the muscle weakness that can go along with it. If it's muscle weakness, the PFTs will obviously present differently. It will not be progressive. It will be just mild and non-progressive restrictive defects with reduced MIPs and MEPs. However, the DLCO will be completely normal versus the reduced DLCO in primary GDM. And the treatment is, again, like a lot of the other diseases, high corticosteroids. If it's very severe weakness, IV solomedrol, weekly methotrexate, cyclosporin, IVIG, cyclophosphamide, and rituximab. So this is just one slide that I have on one patient that I've seen from a different state. He was 3 years old, had presented very typical features of JDM, was started on all the treatments, especially for muscle weakness, since it was very rapid course of disease. About 6 months after he was actually diagnosed, he had respiratory distress and was admitted to the local ER, chest X-ray pneumonia, got intubated, very bad actually course. However, his disease was not related to JDM. He had PJP pneumonia. So one thing to consider, it's not always related to connective tissue diseases. We also have to think about the consequences and immune deficiency. So he right now does not have any lung disease still, and he's now 5.5 years old. He does not have any lung disease related to JDM. He still has only the sequel from the traction bronchiectasis related to the PJP pneumonia that he had. So just to go over it, the systemic sclerosis is the most common one, along with the mixed connective tissue disease for the interstitial lung disease. However, they all can present very often with different features of lung diseases. So that's why I think as pulmonologists, we really have to pay attention to these kids. And we're out. Thank you so much for listening.
Thank you very much, Demet. Thank you. It was a great speech. Thank you.
Yeah, it was on a very difficult topic, but a comprehensive overview and full of cases, and also your experience. I think you deserve to be a shining star, and thank you very much. And also, it's unbelievable. It's unbelievable to have many participants from all over from 4 continents, 9 countries. Especially, I would like to thank our participants from Indonesia, because it's 2:30 at midnight now, and they are still watching us. And also, there are so many participants from Oman, Azerbaijan, Turkey, and also we have our participant from Chile as well, from America continent, USA, and Chile, and Ireland, Egypt, India, and Palestine. So I'm really thankful to all of you. And if there is a question you can ask, you can use the chat button. I know it's late, but if you want to ask something, you can use the chat button. And some people are asking whether they can get your presentation. Is it possible? Can you?
Of course.
Okay.
Yes, of course.
If you send me, I can send them if you want.
I can take out all the unnecessary non-medical slides out. And then I have also a great set of articles that I give also to our fellows to read. I can also put them together and send it to you if you want to share it with your fellows.
Oh, great. It will be great. But also your comments on marriage was also good.
Demet, and also tell Ahmed, say hello to Ahmed and tell him that we are all awake and we're not in our PJs.
No, he told me to check on everybody. He said, like, check on everybody. They should be in their PJs at this time. So,
David, I have a quick question. Is there a registry for interstitial lung disease in USA?
Can you say that once again? Is there what?
Is there a registry for IRD in USA?
Yes. So yes, so it started probably about 6 years ago. So so we have to get consent from all the families and at all types of interstitial lung disease. So it's not necessarily connective tissue disease. It could be, it could be BMT related BOs or any genetic problems or any type of interstitial lung diseases are actually under one registry. And I believe there's also one I've heard of in Europe, but the one in the United States, there had been some closures because the principal investigator had moved institutions, but we actually get consents from all the families and all the clinical data goes into the registry with the chest CTs.
How many patients registered now? How many patients?
I don't know, because there had been some interruption actually for 2 years. So a lot of, for instance, I just hang on to my patients, even if we could not get them to the registry yet. I do not know the final numbers. They just actually started out collecting again. So we're just like waiting for almost 2 years, 1.5 years.
One more quick question and I'm going to stop. And it seems that, these patients need a lot of CT scans during their long-term follow-up. Is there any study evaluating the role of MRI in terms of, evaluating the lung disease?
That's a great question. I always bring that question up actually to our radiologists because I want to get more chest CTs. For instance, the one that I've shown you for the systemic JRA, the one with DeGeorge, she had a lot of chest CTs, but beyond that, not a lot. I had probably only one chest CT on a lot of the kids. So I know that during my fellowship, at Boston Children's, there was a radiologist who was really trying to get something going for MRIs. However, it's just research. And I'm bringing up the question again all the time for our radiologists and other institutions' radiologists too. But MRI is not a good technique to look at the parenchyma and the airways. So instead, if you know that actually you want to focus on one location, for instance, just the ground glass opacities on the basal areas, our radiologists can just focus on that area and they really try to decrease the radiation as much as they can, just to make it easier for the families and obviously less radiation for the kids.
Okay, thank
So what it means, it would take them less time to do the chest CT, right? And a lot of times the kids not even need sedation.
Okay, I see. Thank you.
But MRI is not used. I just wish.
Yeah.
But the duration is so long. Radiologists get concerned that actually to get that done, especially for younger kids, that a lot of these kids would need to get intubated because they will get scared of doing that noise.
A question from Tuba. Have you ever used nintedanib in children?
I wish. I have two patients though, actually, that I'm going to enroll in the study. So it has not been approved for kids. That's the most important reason, actually, that we could not use it. Now it's a double blind placebo-controlled randomized trial that it's coming out. We just got approval, and it's, again, as I mentioned, actually, it's a worldwide study where you can enroll your kids. But it's a total of 50 kids through the United States and 50 through Europe, and they have to actually fulfill certain criteria. But we could just use it for those two kids under the umbrella of the study. And obviously, since it's placebo-controlled, I don't know actually, if they would be placebo or medication. I would not know either. However, when I talk with the adults, actually, they have been using it quite widely for a lot of patients, and especially for IPF and systemic sclerosis. And the most important side effect is GI symptoms. So they have to make sure that actually the adults, or the patients do not have any thrombosis or any thromboemboli or any liver disease. That's the most common side effect. But otherwise, I think it's fairly safe.
And another question from Tuba. Do you use anti-MDA5 antibodies for evaluating pulmonary involvement of DM or GI?
For JDM?
JIA. And
MDA, did you say MDA5?
MDA5, yeah.
5.
So no, we don't use that one. For the JIA patients, actually, we have not a clinical base, but we sent different inflammatory markers like the CXCL9, S100, and the IL-18 levels. And it's only one center in the United States. It's Cincinnati Children's, which does those studies. We send it there. And again, this is not necessarily a clinical thing that we can follow. Not official, as you know, I miss being in Turkey, and doing things sometimes, in my own mind. Here, you cannot do things if it's not FDA approved or blah, 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 right? So, so we send it out just for our own curiosity, just to see if the immune suppression we give, it's enough. But it's, again, those are more research lab parameters that we use. It's this, S100, IL-18, and the CSXCL9 that we use. Yeah, but not MDA5. The MDA5, there are studies that they look into for more so juvenile dermatomyositis patients. But yeah, we never use it for JIA.
Another question from Nagihan Emir Alioğlu from Hacettepe. Thank you for your nice presentation. She would like to ask your opinion about the pulmonary side effects of biological agents in this disease to differentiate from the primary lung involvement of disease. How can you differentiate?
That's a very good question. So there have been some very good articles recently over the last 2 years to see if the pulmonary problems could have been related to the medications itself, the biologics, versus the disease itself. And it's really hard to differentiate those, right? But for a lot of these kids, if it is related to medications, you'll see also some eosinophilia. That's the main presentation, actually. So for instance, for JIA, and the last two researchers, and I'm happy to actually include those papers in the package as well. So it was a paper that enrolled a lot of kids nationwide and looked into the data for these kids who could have been having some side effects from these biologic agents. And a lot of these kids were actually trisomy 21. That was one of the things. And the other thing for the blood work actually was that they had eosinophilia, not necessarily inflammation. And those kids actually, and there's one more thing that they've been looking into, but it's not published yet, or is in the process of being published. They also have one genetic mutation actually, which makes them more prone actually to those potential allergic side effects of the biologic agents. For instance, the kid that I mentioned, For the SJIA, she was trisomy 21, so she had already one thing. She had eosinophilia. She had all the side effects related to anakinra and the tofacitinib. And then the reason that we stopped the anakinra was actually helping with inflammation, but unofficially, Stanford, her blood work had been sent to Stanford for the genetic studies, and Stanford unofficially told us that she did have that gene positive, which would make her more prone to some sort of anaphylaxis. And since she did have this initial presentation when she had the MAS with some systemic side effects to the medication, we stopped it. We said, we cannot take the risk again. We cannot go to square one and have her, go back to MAS. So when she first presented to MAS, she did have a lung biopsy. I did not present those slides actually, because she was so complicated. We didn't know actually if she could have been medication side effect, if she could have been SGIA, or, if she could have actually some cardiac problems, because she had also heart failure at the time. So she had a cardiac cath. She did not have pulmonary hypertension at the time. And her lung biopsy actually demonstrated some pulmonary lipoproteinosis, which could have been related actually to the medication side effect. It was not pulmonary alveolar proteinosis. It was lipoproteinosis that I mentioned. And it was very patchy, which brought up the concern that it could have been some medication side effect.
Thank you very much. As far as I see, there is no more question, but you can also ask questions afterwards. If you want, I can give her email as well. And I really thank you, Emma. So we are proud of you having such a great expert in US and with the Turkish origin, and also now giving motivating all people all around the world. Thank you very much, really. And hope to see you soon. Next month, we will have additional meetings and interesting meetings, and hope to meet you all next month. Thank you very much, Demet.
Thank you so much for having me. Thank you. I appreciate it. It's a big honor.